The Ophthalmic Nursing Assessment. Presentation by Jacob McInnes, developed from the Essentials of Ophthalmic Nursing by the American Society of Ophthalmic Registered Nurses. The educational objectives. List the three main components of a nursing assessment. Contrast the subjective and objective data used in performing an assessment. Explain the difference between a medication allergy and a medication sensitivity. Discuss a comprehensive review of systems versus an ocular review of systems. Describe the meaning of standard Snellen visual acuity documentation. Describe the process of assessing the visual acuity of a patient with low vision. List three alternative testing methods for pre-literate or illiterate patients. Name three methods of assessing a patient's visual field, and list the three cranial nerves necessary for extraocular movement. Whether the ophthalmic nurse is working in general ophthalmology or a subspecialty of the field, the foundation of care rests on the ability of the nurse to have exceptional skills in nursing assessment. In accordance with the Nurse Practice Act, nursing assessment is the holistic determination of a patient's actual or potential health needs. The components of this assessment include a comprehensive history, a psychological and social examination, and a physical examination. This module will review those components with an appreciation for the special circumstances and skills necessary for a registered nurse working in ophthalmology. This module will describe the patient assessment by the nurse from admission to discharge. There will be a review of the information required from the patient, effective patient interviewing skills, and the most common examination techniques. The module also includes a description of comprehensive ocular assessment that highlights normal and abnormal findings. Subjective data is information obtained through interviewing a patient. The subjective data is a patient's perception of their health. Obtaining accurate and complete information is crucial to providing good ophthalmic healthcare. It's important to remember that complete information does not mean all of the information that we're going to discuss here, but rather the appropriate information regarding the circumstances of a particular patient encounter. The amount and type of information obtained and the method of collecting it may vary depending on the setting, the situation, and the patient. Consider the following variables and their potential impact on a patient encounter. The setting in which we see the patient, whether that's an office, a hospital, or a surgery center. The situation in which we're seeing the patient. Are they a new patient, an established patient, a preoperative patient, a postoperative patient? Is this a routine visit versus an emergency appointment? And then patient variables as well, like age, ethnicity, gender, their primary language, level of orientation, and their comfort level. There are 7 categories of subjective data needed from the patient: demographic data, a medical history, psychosocial history, family health history, a review of systems, a chief complaint, and then the history of the present illness. In many practices, demographic data is something that will be collected by administrative staff. The following components fall into this category: name, birth date, age, sex, occupation, address, telephone numbers, email addresses, and emergency contacts. Medical history. The patients have a unique perception of their current health status. Consider asking the patient to rate their overall health in terms of good, fair, or poor as a first step in defining their current health status. In order to objectify their perception into something more measurable, you can query the patient about the following. When was their last comprehensive physical examination? When was their last comprehensive eye examination? Is exercise a routine part of their life? How much sleep do they get each night? Could they describe their average diet? And for female patients, when was your last menstrual period? And is there a chance of pregnancy? The ocular history should include previous ocular injuries or surgeries, any chronic ocular disorders, patients' use of corrective lenses like eyeglasses or contact lenses, and any childhood history of poor vision or patching. There are even instances when reviewing old photographs may be helpful in documenting a history of certain ophthalmic disorders, like pupillary abnormalities, muscle imbalances, and heterochromia iridis. A systemic history includes childhood illnesses, adult illnesses, medications, a surgical history, hospitalizations, significant emergency department visits, and any psychiatric history. Of particular importance due to their potential for ophthalmic manifestations are chronic diseases like diabetes, hypertension, cardiovascular disease, obstructive or restrictive pulmonary issues, arthritis, intracranial lesions, neuromuscular disorders, collagen disorders like sarcoidosis, lupus, and Ehlers-Danlos syndrome, immune disorders like HIV, Reiter's, Sjogren's, and ankylosing spondylitis, and endocrine disorders like Graves' disease. With the increasing prevalence of resistant bacterial disorders, such as methicillin-resistant Staphylococcus aureus or MRSA, it's also important to include these in the patient's history. When obtaining a medication history, include the name of each medication, its route of administration, the dosage, and the frequency. In addition to prescription medications, include all eye drops, over-the-counter medications, oral contraceptives, herbal supplements, injections, and topical preparations. Knowledge of past medications, especially from the recent past, is also useful. If a patient is on blood thinning medications like aspirin, clopidogrel, and warfarin, ask the patient for the name of the prescribing physician. This will provide useful information for obtaining medical clearance for surgical patients. Reactions to medications should be documented carefully, as patients often report a side effect as an allergy. A true allergy to a medication results in an immune system response, while medication sensitivities are often just an exaggerated response to a known side effect. You should inquire and document any allergies, sensitivities, or medication intolerances at every visit, as this information may change frequently. Documentation should include not only the name of the medication, but also the patient's reaction. The psychosocial history may include education level, cultural ethnic backgrounds, current household status, current marital status, a sexual history, and the use of alcohol, tobacco, and/or recreational drugs. Many of these questions may be sensitive topics for patients, so it's important to assure the patient that this is part of their confidential medical record. Alcohol intake should be documented in terms of amount and frequency. One drink is equivalent to one glass of wine, one bottle of beer, or one shot of liquor in a mixed drink. For tobacco, be sure to ask about all forms of tobacco, like cigarettes, pipes, chewing tobacco, cigars, and vaping. Inhaled tobacco should be documented in the medical record in terms of years of smoking. To calculate this, use the following equation. Number of pack years equals packs smoked per day multiplied by years as a smoker. The family health history provides vital information as far as the identification of potential and actual risk factors. Grandparents, parents, and siblings should be included in this history taking. This history will help identify any inherited disease or diseases with genetic predispositions that may also have ophthalmic implications. A review of systems, or ROS, documents the presence or absence of common elements across 14 major body systems. These include constitutional, eyes, ears, nose, mouth, and throat, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, integumentary, neurological, psychiatric, endocrine, hematologic, lymphatic, allergic, and immunologic. For new patients or for a history and a physical, a complete review of systems is necessary. However, for follow-up patients, the review of systems should be focused and pertinent to the reason for the patient's visit and will most commonly be focused on ocular review of systems. Common elements in an ocular review of systems include change in vision, blurred vision, photophobia or light sensitivity, scotomas or blind spots, pain, piphora or tearing, dryness, itching, diplopia or double vision, halos, glare, flashes and floaters, redness, drainage, and injury. The chief complaint, often abbreviated CC, is the reason the patient is seeking care. It's important to record the chief complaint in the patient's own words. Therefore, record the patient states lights bother me and don't record the patient is photophobic. It is possible to have more than one chief complaint. A patient can have a secondary chief complaint, a tertiary chief complaint, and so on, and they should also be documented. The history of the present illness, or HPI, is an expansion of the chief complaint. It provides a chronological description of the patient's current illness. Obtaining a complete HPI requires the nurse to be able to elicit relevant information using successful interviewing skills. Often these skills are acquired through time and experience in the field. There are 8 key elements included in a complete history of the present illness. The 8 key elements of a history of present illness include the location, its anatomical location. Is it unilateral versus bilateral? Is the problem fixed or is it migratory? Are the symptoms diffuse or are they localized? The quality. Is it sharp, dull, throbbing, stabbing, constant, intermittent, acute or chronic, improving, stabilized, or worsening? The severity. Use an age-appropriate pain scale and look for nonverbal signs of discomfort. The timing. What's the onset? What's the chronological account of this patient's complaint? The context. What are the circumstances or factors surrounding this event? What precedes or follows a symptom? Its duration. When did the symptoms start? Modifying factors. Are there things that make it better? Are there things that make it worse? And associated signs and symptoms, which are additional sensations or feelings associated with the problem. Don't forget to include pertinent negatives. These details help to define the differential diagnosis. It's a good idea to get into the habit of including at least 4 of the 8 HPI elements in your HPI, as, for most cases, that number will meet the minimum criteria for most evaluation and management coding requirements. When documenting an HPI, it's important to distinguish between signs and symptoms. Symptoms are the patient's subjective complaints and are documented in the history portion of the patient record. Those are pain, itching, double vision. Signs are observable phenomena that are documented in the examination portion of the patient record. Those are tearing, discharge, unequal pupils, drooping lids, ocular deviations, etc. Information that can be measured through physical examination, observation, or diagnostic testing is objective data. Visual acuity at a distance should be checked on both eyes of all patients at each visit. Visual acuity should be checked both with and without correction at the patient's initial visit to determine a baseline, and then afterwards the patient may wear their habitual correction as applicable. In an ophthalmological exam, the right eye is always checked first. You will follow this pattern through the entirety of the encounter. Remember to completely occlude the non-testing eye by using an occluder or by asking the patient to cover their eye with tissues. Remind patients to avoid squinting or straining, as this may alter the test results. Proper documentation of visual acuity requires that you be familiar with the most common visual acuity notations. These are some of the standardized visual acuity notations. VA is visual acuity. VACC is visual acuity with correction. VASC is visual acuity without correction. N is for near. D is for distance. PH is for pinhole. OD, or ocular dexter, is for the right eye. OS, or ocular sinistra, is for the left eye. OU is for both eyes. CF is for count fingers. HM is for hand motion. LP is for light perception. NLP is no light perception. FF is fix and follow. And CSM is central, steady, and maintained. The Snellen letter chart is the most common method of evaluating visual acuity at distance. This chart employs the use of optotypes, which are simply a combination of standardized numbers, letters, or geometric shapes of varying sizes. Visual acuity using the Snellen chart is recorded in a fraction format. However, this is not a normal fraction. It's a comparison of the tested person's vision to a normal patient's vision. The number recorded in the denominator position is the testing distance, which is typically 20 feet, or if the room is smaller, a calibrated 20 feet, while the number recorded in the numerator position is determined by the smallest optotype that can clearly be seen and distinguished by the patient. A visual acuity of 20/20 is considered normal vision. A visual acuity of 20/60 means that the tested person identifies letters at 20 feet that a normal person would have been able to identify at 60 feet. A visual acuity of 20/15 means that the tested person identifies letters at 20 feet that a normal person would be able to identify at 15 feet. This, of course, is better than normal visual acuity. When a patient misses more than half the letters on a line, record the previous line as the visual acuity, noting the number of letters missed on the current line as a superscript with a minus sign. Alternatively, when a patient is able to completely read one line and can also read several letters on the next smallest line, then document those additional letters as a superscript with a plus sign. These are some examples to show what we're talking about. The patient reads the 20/40 line with 3 missed letters. We would document that as 20/40 minus 3. A patient reads the 20/25 line with 2 missed letters. We would document that as the 20/25 minus 2. If a patient reads the 20/30 line with 1 additional letter read on the 20/25 line, that would be documented as 20/30 plus 1. If a patient reads the 20/50 line with 2 additional letters on the 20/40 line, that would be documented as 20/50 plus 2. Some tips for checking vision. If you have any suspicion that a patient has memorized the chart, maybe consider scrambling the letters or using a different type of chart. In cases where a patient's vision is below normal in the absence of a known ocular condition, extend the patient testing to include a pinhole acuity test. A pinhole occluder, like the one seen here in the upper left, allows only a fine line of central light into the eye. This stimulates a refractive correction. If the patient's vision improves by 2 lines or more using the pinhole occluder, it's likely that they have a refractive error and can be evaluated for glasses. Another helpful tip, if you know a patient has a retinal disorder that impairs their central vision, sometimes by having them look just to the side or using eccentric vision will allow them to focus the chart on a different part of their retina that doesn't have any disease. This may allow them to read the eye chart. There may be instances when you are working with preliterate or illiterate patients. There are several charts that can be helpful in assessing vision in these patients, and they are, in order of preference, the HOTV chart. Here, a patient is handed a card with the letters H, O, T, and V on it, and they can point to the letters in the order that they see them on the chart. Next is the LEA symbols. Again, sometimes a patient is handed a card with these symbols on them. They are often used in pediatric settings and include a circle, a square, a house, and an apple. And as these symbols get smaller, they are harder to distinguish from each other and more closely reflect actual visual acuity than the Allen figures. The rolling E chart is evaluated by a patient, and generally you ask the patient to point in the direction that they see the E as they read the chart. Allen figures are commonly used in pediatric settings as well, but are considered inferior to the LEA symbols because they are distinct even as they do get smaller. And what child knows what a rotary telephone is these days? There's also fixation behavior. Fix and follow methods are often used with infants. You usually hold a brightly colored toy in front of them to assess if they can fixate on the object, and then you move it around to see if they can follow it. Visual acuity at near is a measurement of a patient's reading distance. Standard reading distance is considered 14 inches, and acuity is measured against the standard of a normal person's visual ability. Near visual acuity should be checked in all patients at their initial visit to establish a baseline. All children, patients complaining of near acuity problems, and patients near or in the presbyopic age range. One of the most common methods for checking near vision acuity is the Rosenbaum pocket chart, which uses optotypes that are similar to the Snellen chart. An alternative method to check near vision is something called a Jaeger chart, which uses text of varying sizes and instead of documenting the visual acuity in a fraction format, uses a Jaeger notation in which a larger point size text is associated with an increase in the J number. Here we see 2020 is equal to J1 plus, 2025 is equal to J1, 2030 J2, 2040 J3, 2050 J5, 2070 J7, 2100 J10, and so on as the visual acuity worsens. Low vision is generally defined as an inability to see the 2200 optotype at 20 feet. Patients with a history of glaucoma, cataracts, macular degeneration, or other retinal diseases, as well as patients with a hereditary or congenital vision abnormality, may fall into this category. The first step in checking vision in these patients is to test at distances closer than 20 feet until the patient is able to see the 2200 optotype. If a patient is able to see the 2200 optotype at 10 feet, your notation would be 10, 200, which indicates the patient is able to see the 200 optotype at 10 feet. If the patient is unable to read the 200 optotype, despite getting closer to the chart, then you will proceed to hand motion vision. You will not use count fingers vision because there is wide variation in hand sizes and hand colors, and we prefer a standardized method of checking vision. Hand motion detection uses vertical and/or horizontal hand movements and is documented as HM at the detectable distance. Usually this will be in the 1 foot range. The final step, if all of these things are impossible for the patient, is to test for light perception. Tightly occlude the patient's other eye and use a pen light or a light from an indirect ophthalmoscope and darken the room to assess whether the patient is able to perceive light. LP, or light perception, indicates that the patient is able to see the light source. Bare LP indicates that the patient is only able to see indirect light. And NLP, or no light perception, indicates that the patient is unable to see any light. Glare and contrast sensitivity testing are used to evaluate patients with posterior capsule opacities, patients after refractive surgery, or patients to justify cataract surgery, and to evaluate patients who report visual discomfort in the presence of bright light. Glare testing tests the degradation of vision in the presence of bright light, while contrast testing tests the degradation of vision under circumstances of poor contrast. Glare is categorized into two groups: discomfort and disability. Discomfort glare is caused when a bright light creates visual discomfort. This type of glare is seen in certain ocular conditions like uveitis, ocular albinism, cone rod dystrophy, and retinitis pigmentosa. To test for discomfort glare, the examiner shines a pen light toward the patient as they try to read the visual acuity chart, and while doing so notes any discomfort that the patient is having as the light source increases. Disability glare occurs when a bright light is scattered by ocular media, resulting in reduced visibility and decreased contrast of the object. Disability glare is most common in patients as they age, in the presence of cataracts, and after cataract surgery. There are multiple tests available for evaluating disability glare. Among the most reliable is the brightness acuity test, seen here in the lower right corner. The potential acuity meter, or PAM, directs a Snellen chart, or a series of red lines, directly through the pupil and onto the retina, bypassing any lenticular opacities. This test evaluates visual acuity through a media opacity to assess what the potential vision would be if that opacity was removed. This test is most commonly used prior to cataract surgery in patients with a history of retinal disease to help determine how much visual loss is due to the retinal disease as compared to the opacity, and therefore determine the overall visual benefit of the cataract extraction. Multiple recent studies, though, suggest that clinical judgment may prevail over the benefits of using a potential acuity meter. Assessing color vision. Evaluating for dyschromatopsia, or color blindness, is an important part of the patient exam. Dyschromatopsia is an X-linked recessive disorder, meaning that mothers pass the disease onto their sons, so it's much more prevalent in men than it is in women. While heredity is the most common reason for color blindness, acquired color blindness is a key indicator of optic neuropathy, retinopathy, and medication effects. Color vision testing evaluates the integrity of the cones in the retina, which are concentrated in the fovea, and identifies defects due to deficiency or absence of one or more of the visual pigments, red, yellow, and blue. Anomalous trichromatism for red and green is the most common alteration in color perception. The most common way to test for this color perception deviation is with Ishihara color plates, seen here. These are a number embedded in colored circles that patients with a red-green color abnormality have difficulty seeing. Here we see the Hardy-Rand-Ritter plates. This is a combination of three symbols, a triangle, an X, and a circle, again embedded in colored circles, that are difficult for patients with acquired colored blindness to see. And another test is the Farnsworth-Munsell D15, which has patients grade colors by their shade in a row and is also useful in acquired color deficiencies. Manometry is an indirect estimate of intraocular pressure, or IOP. Intraocular pressure is measured in millimeters of mercury, and in general, the normal range for IOP is 10 to 22 millimeters of mercury. There is diurnal variation, and it can change from hour to hour. Children under the age of 12 may have measurements slightly lower than that range, but most studies support that by middle childhood, IOP reaches that of an adult. Intraocular pressure is largely dependent on the amount of aqueous humor that is secreted by the eye and the ease by which it leaves the eye. There's a lot of different ways that we can check eye pressure. Almost all of them require numbing medications and some degree of training. Some instruments are handheld, like the tonopen at the bottom of the slide here, but the gold standard is applanation tonometry, seen here, which requires the use of a slit lamp microscope. Extraocular muscle function is the evaluation of eye movements and muscle balance. Extraocular muscles, or EOM, are checked by evaluating the primary gaze and the 8 cardinal gaze positions at an initial screening and on most patients at each visit as part of the basic exam. A more extensive examination may be warranted in pediatric patients who have a history of strabismus, pediatric patients with vision loss in one eye, or adults and children who are experiencing diplopia or double vision. The evaluation of the gaze positions is a test which will provide a gross examination of the EOM movement. In each position of gaze, one muscle of each eye is the prime mover. Should there be a motility restriction, the examiner should be able to localize the muscle involved based on the cardinal position affected. So here we have right and up, which uses the right superior rectus muscle and the left inferior oblique muscle. If a patient looks directly right, that's the right lateral rectus muscle and the left medial rectus muscle. If a patient looks right and down, that's the right inferior rectus muscle and the left superior oblique muscle. If a patient looks directly up, that's the superior rectus and inferior oblique muscles. The primary gaze, or straight ahead, involves a balance of all of the extraocular muscles. If a patient looks directly down, they're using their inferior rectus muscle and their superior oblique muscle. If a patient looks left and up, they're using their right inferior oblique muscle and the left superior rectus muscle. If a patient looks directly left, they're using their right medial rectus muscle and their left lateral rectus muscle. And if a patient looks left and down, they're using their right superior oblique muscle and their left inferior rectus muscle. Tests of binocularity and fusion. Stereopsis testing evaluates binocular fusion by measuring the fusion of images viewed at different angles by each eye. Any child suspected of having a unilateral visual deficit should undergo this testing, as well as adults in certain occupations requiring good stereo acuity. One of the most common methods to test stereo vision is the stereo housefly, the stereo circles, and the stereo animals. Tests of ocular alignment. Corneal light reflection tests demonstrate proper ocular alignment. These tests require that a patient focus straight ahead at a fixed target while the examiner directs a penlight at the eyes. The corneal light reflex is compared. If it's asymmetric, as we see in some of these examples, the result indicates a deviation. The most common corneal light reflection tests are Hirschberg's and Krimsky's tests. Krimsky's test utilizes a prism and is therefore considered more accurate in determining the degree of deviation. The cover and uncover tests and alternate cover tests are used to identify misalignment of the eyes. Both variations use an occluder to cover one eye while observing the other eye for a deviation. Visual field testing measures the visual function of the retina and identifies loss of visual field and associated functional incapacity. While the results of the visual field testing are dependent on subjective patient replies, a visual field should be reproducible. Visual field testing is essential for the ongoing assessment of glaucoma patients, thyroid eye disease patients, secondary to the risk of compressive optic neuropathy, any patient with complaints of a scotoma, patients with evidence of an intracranial lesion like papilledema or neurological signs or symptoms, and lastly, in patients who report a visual field loss secondary to ptotic or heavy eyelids. Really, there are about 3 ways that we can measure a patient's visual field. A confrontation visual field test is a gross assessment for visual field defects. This assessment uses the examiner's visual field, which we presume is normal, and compares it to the patient's visual field. Really, this is more of a screening tool, and if any abnormalities are found, those should be followed up by a more detailed assessment like a computerized visual field test or a Goldman manual perimetry. But in doing a confrontation visual field, you should ensure that you sit directly in front of the patient, having your eyes level with theirs. you should have the patient to close one eye completely with their hand while observing your open eye with the other. And then, holding your hands in your peripheral vision, you should begin to wiggle your fingers and ask the patient to indicate when they can see them. Any areas where the patient can't see the fingers wiggling should be marked on the chart. Computerized tests like the Humphrey or the Octopus visual field provide a detailed assessment and are able to detect very early changes in retinal nerve fibers and a more precise delineation of a scotoma. Goldman perimetry is a manual test whereby scotomas are plotted on a special chart by hand. Manual perimetry is more commonly used in evaluating patients with complaints of heavy or drooping eyelids secondary to ptosis or dermatochalasis. In the normal visual field, the macula corresponds to the center of the visual field, which is at the intersection of the horizontal and vertical axes. There is a physiologic blind spot, or normal scotoma, on the visual field that corresponds with where the optic nerve exits the eye. In the right eye, this blind spot is located between 10 and 15 degrees to the right of the macula on the horizontal axis, and in the left eye, between 10 and 15 degrees to the left of the macula on the horizontal axis. Visual sensitivity is highest in the macula and decreases towards the edge of the visual field. The approximate boundaries of a visual field in a normal disease-free person are 60 degrees superiorly, 75 degrees inferiorly, 100 degrees temporally, and 60 degrees nasally. Assessment of ophthalmic structures. Assessment of the eyebrows, eyelashes, eyelids, and lacrimal system. Our examination technique includes inspection with and without slit lamp microscopy, palpation to identify any abnormal growths, nasal lacrimal patency tests, and Schirmer tear function tests. Our normal findings will be symmetry of all structures, lashes that are evenly distributed and curve outwards, lacrimal ducts that are patent without any discharge, normal tear production, and intact skin. Here we can see an example of a very normal external eye exam. There are some important eyelid measurements. Remember, the palpebral fissure is the vertical distance from the central lower lid to the central upper lid margins, and that's anywhere from 7 to 12 millimeters. The margin reflex distance is the distance from the light reflex of the pupil to the upper eyelid margin, and that's 4 to 5 millimeters. The margin reflex distance 2 is the distance from the light reflex of the pupil to the lower eyelid margin, and that's 4 to 5.5 millimeters. The levator excursion is the difference between down gaze and up gaze, represents the levator function, and normal is 15 millimeters plus. Good is 12 millimeters plus. Fair is 5 to 11 millimeters plus, and poor is 4 millimeters or less. The upper lid crease is the distance from the central upper lid margin to the central crease. And in women, it tends to be a little bit longer, 10 millimeters, than in men who average about 8 millimeters. Scleral show is the amount of white that is visible above or below the cornea. And this is variable, but should be measured in millimeters. And then lag ophthalmos describes the incomplete or abnormal closure of the eyelids. And there should be no lag ophthalmos. If it is present, it should be measured in millimeters. Here we have some select abnormal findings of an eyelid, eyebrow, eyelash exam. In our first example, all the way to the left, we have ptosis, or lid drooping. This can occur unilaterally or bilaterally in some patients. In the middle, we have a hordeolum, sometimes known as a stye. So here we can see this very large growth on this person's lower eyelid. Sometimes these hordeolums are external, and sometimes they are internal, and they cause great discomfort for the patient. And then we have an ectropion, or a drooping lower eyelid. Here, the eyelid turns out and is lax and not taut against the eye, and this would be considered for a surgical evaluation. The assessment of the orbit. Our examination techniques will include inspection, ophthalmometry, corneal reflection pupillometers, and diagnostic testings like X-rays, CT scans, and MRIs. There are some normal orbital measurements. The intercanthal distance, or the distance between the two medial and two lateral canthi, is considered normal at 30 millimeters. The interpupillary distance, or PD, is the distance between the center of the two pupils. An average PD for an adult is 61, but it can vary. And then the anterior-posterior position of the globes, we use exophthalmometry to measure this. And normal distance is 17 millimeters difference, and any difference greater than 2 millimeters is considered abnormal. Again, we have some abnormal orbital findings to go over here. First on the left is telecanthus, and this is a very large nose bridge in between the patient's canthi. This can be corrected with surgery. Then we have N-ophthalmos. Here, one eye is generally much smaller than the other. It may be poorly developed or it may be fully developed. And then we have X-ophthalmos, and this is a protruding eye. Typically, we would see this in patients with Graves' disease. An assessment of the cranial nerves is a vital part of the ophthalmic exam, as it really provides clues to ocular pathology. 6 of the 12 cranial nerves are involved in some aspect of vision or eyelid function. So first we have the big one, cranial nerve 2, the optic nerve. Its function is vision. How do we test it? We check vision, we check color vision, we check confrontation visual fields, we check visual reflexes, and we can do a fundoscopic exam. Cranial nerve 3, or the oculomotor nerve, primary function is extraocular movement. Here we can assess a patient's cardinal gazes and their pupillary response. Cranial nerve 4, the trochlear nerve, also involved in extraocular movement, and again we're going to assess it by the cardinal gazes. Cranial nerve 5, the trigeminal nerve, is a sensory supply to the face and cornea, and we can check this by doing a corneal reflex test. Cranial nerve 6, the abducens nerve, is also involved in extraocular movement, and again we're going to assess that through the cardinal gazes. And then cranial nerve 7, the facial nerve, involves motor branches for facial movement, and here we can assess it by closing eyes against resistance or inspecting for signs of facial asymmetry. Assessment of the pupils. The evaluation of pupils is very, very important. And we're going to assess both constriction and dilation functions, size, shape, and equalness. Pupils should be assessed at every single visit, with particular attention paid to patients suspected of having neurologic injuries, retinal detachments, or history of head injuries. When assessing the pupils, our examination technique is going to involve a few things: a direct light reflex, a consensual light reflex, an accommodative response, and the assessment of size and shape. In normal findings for pupils, it's important to note that the acronym PEARL or PEARLA, where pupils are equal, round, reactive to light, and accommodation, is no longer considered a valid descriptor of pupil status. While this notation is commonly used by generalists in medicine, it is largely outdated in the field of ophthalmology. Pupil size varies among the population, but in general, pupil sizes range from 3 to 8 millimeters. Notation of pupil findings should be right eye and left eye, the size that the pupils are at rest, and then the size that the pupils are when they have a direct light on them. The pupil should be round and equal in size when compared to the contralateral pupil, And the most important test in evaluating pupil function is a swinging flashlight test, which evaluates the direct and concentric response of the pupils. An abnormal test indicates an afferent pupillary defect or a Marcus gun pupil. Here are a few abnormal findings when we're doing a pupillary assessment. On the left, we have an isochoria, or unequal pupils. Here we can tell this patient has one very large pupil and a very normal pupil. And this can happen for a number of reasons: concussions, swelling on the brain, and so it should be brought to a physician's attention immediately. In the middle, we have Marcus gun pupil, or an APD, and here we can see that the pupils are equal when there is no light. We can see a normal response to light when a light is shown in the left pupil. And then when the light is shown in the right pupil, we're seeing an abnormal response where the right pupil and the left pupil dilate. This indicates that there is an APD in the right eye. And again, this is something that should be brought to the physician's attention. And on this side, we have Horner's pupil. Here we see a patient with mild lid ptosis and a myotic pupil, or a smaller pupil than his eye that is not experiencing any ptosis. Again, this should be brought to a physician's attention immediately. Assessment of the conjunctiva and the sclera. Our exam technique here will be inspection with and without slit lamp microscopy, upper lid eversion to evaluate tarsal conjunctiva. Remember, the conjunctiva is continuous with the eyelids, and palpation of scleral firmness through closed lids to evaluate pressure by finger. This is something that should be done only as a last resort if there is no other way to evaluate patient eye pressure, as it is very inaccurate. Our normal findings show a conjunctiva that is translucent and moist with rich vasculature, and the sclera should be opaque and white in color. Here we have a normal example of a nice conjunctiva with an underlying sclera. Here are some abnormal findings when we're looking at the conjunctiva and the sclera. Our first example is pink eye or conjunctivitis. Here we can see that the eye is very inflamed with rich discharge coming from it. This is often related to a bacterial or a viral infection. In the middle, we have a subconjunctival hemorrhage. This is a bleed that takes place below the conjunctiva, in between it and the sclera. It can be quite striking, but it is largely just considered a bruise and will heal within a week to 2 weeks depending on the amount of blood thinners that the patient takes. On the right-hand side, we have a pinguecula, which is a growth underneath the conjunctiva above the sclera that can become inflamed and hardened and really irritate patients. When assessing the cornea, our examination techniques will include inspection with and without slit lamp microscopy, fluorescein staining to assess surface integrity, pachymetry to determine corneal thickness, and specular microscopy to evaluate endothelial cell counts. The cornea, if it's normal, should be clear and completely avascular. Again, here are some abnormal corneal findings. On the left-hand side, we see a pterygium, which is a growth from the conjunctiva onto the cornea. And this can become inflamed and painful for patients and can also impair their visual axis. If it's not inflamed and not painful and not on their visual axis, it can sometimes be left alone. Keratoconus is a cone-shaped cornea. Here, a patient will present with high astigmatism and possibly corneal thinning. There are many methods to help treat keratoconus. Some of them are surgical and some of them are non-surgical. And here we see an example of a dendrite, this little green speck with tails coming off of it. This is often seen in patients with herpetic illnesses, especially herpes zoster or shingles, after it becomes involved with the trigeminal nerve. Again, here, this can become painful. It is often treated with antiviral medications and sometimes does require surgical intervention. When we're assessing the anterior chamber, our examination techniques are going to include inspection, oblique light to assess the depth of the chamber, slit lamp microscopy for detailed inspection, and gonioscopy to assess angle structure. Our normal findings of the anterior chamber is that it should be deep, there should be no debris, and the patient's angles of their trabecular meshwork should be open. Here are some abnormal findings in the anterior chamber. On the left, we see a hyphema, or blood that is starting to fill the space between the cornea and the iris. Sometimes this is associated with surgical interventions. Sometimes this is associated with trauma. Here in the middle, we see a hypopyon. On the surface, we see a corneal ulcer, and then behind the corneal ulcer, between the iris and the cornea, we see this white deposit. This is pus, and this is usually indicative of a very bad infection in a patient. And then all the way to the right, we see a flat chamber. Here we can determine that the patient's iris is touching the cornea. And sometimes this happens after surgery or trauma, or if the eye pressure goes very low. All of these are pretty urgent situations and should see a physician quickly. When we're assessing the iris, our examination technique is going to be inspection with and without slit lamp microscopy. Normal findings include symmetry of color, structural integrity with no abnormal movement, and no abnormal growths or neovascularization. Again, here are some selected abnormal findings. On the picture all the way to the left, we see a nevi or a nevus. This is like a freckle that we get on our skin. People can get them on any surface of their eye, and it's something that we generally observe to ensure that it's not growing, it's not changing, and it's not becoming cancerous. Rubiotic blood vessels are typically seen in patients that experience things like diabetes, diabetic retinopathy, central retinal vein occlusions. Here you can see these fine blood vessels that are starting to perfuse over the surface of the iris. These can impair flow from the trabecular meshwork and cause what we call neovascular glaucoma, very high eye pressures. And then transillumination. This is seen in patients with conditions like pseudoexfoliation and pigmentary dispersion syndrome. When a light is shined through their pupil, that light reflects off of the retina and then back through the iris. And here you can see where this patient is losing pigment from their iris. In an assessment of a patient's crystalline lens, we're going to use inspection via ophthalmoscopy and slit lamp microscopy. Normal findings in a patient is that the lens should be clear and it should be centered behind the iris. Here are selected abnormal findings. All the way to the left, we see a nuclear cataract. This is fairly standard. This patient would benefit from cataract surgery. In the middle, we see a cataract that has had much more time to develop a brunescent cataract or a Morganian cataract. The difficulty with these is that they can become much more difficult to remove from a patient's eye, and they can also start to break down and cause lenticular glaucoma. And then all the way to the right, we see a dislocation of the lens. Here you can see the very edge of the lens as it is sunsetting behind the iris. And this can happen for a number of reasons. You'll see it in patients with connective tissue disorders, but you'll also see it in traumatic injuries. An assessment of the vitreous, or the jelly that's behind the lens in front of the retina. Our examination techniques are going to include inspection with direct and indirect ophthalmoscopy, stereoscopic magnified microscopy with a lens and a slit lamp, and then sometimes special examinations if we suspect foreign bodies within the vitreous, like an X-ray. Its normal findings should be completely transparent, and most people have some degree of vitreous floaters or entopsia that can be seen. So here are our abnormal findings. Here is a vitreous hemorrhage. This is a lot of blood that has filled this patient's vitreous area. Sometimes they will filter the blood out of their body naturally. Sometimes they will require surgery. This can be associated with a lot of things from trauma to diabetic retinopathy. In the middle, we see opacities. This is a condition called asteroid hyalosis. These are small deposits within the vitreous with really no known explanation in humans. Most patients aren't bothered by them. Some patients will be, and they'll request surgery. And then foreign bodies. Here, this is a large metallic foreign body that is sitting in this patient's vitreous, likely from a penetrating injury and likely needs to be surgically corrected. When doing an assessment of the retina, we have a few examination techniques at our disposal. There's inspection of the retinal surface, which uses direct and indirect ophthalmoscopy, and stereoscopic magnified microscopy with a lens and a slit lamp. We can do dye tests like fluorescein or indocyanine green angiography to identify abnormal vascularization while we take pictures with a special filter on a camera. We can do ultrasonography to identify detachments. We can use fundus photography to identify changes over time, and optical coherence tomography to evaluate the different layers of the retina, as well as confocal scanning laser topography. Normal findings in a retina show that a red reflex is present and that it is firmly attached to the choroid. Here are our abnormal findings. All the way to the left, we see a retinal detachment. Here you can see that we've lost detail underneath this little cloud. That's actually retinal tissue that's coming off. Remember, it's very firmly attached at the optic nerve. This patient very likely needs surgery. In the middle, we have hemorrhages or other exudates, and this is an example of dry macular degeneration. These little yellow dots in the middle of the photo are called drusen and are typical of the earlier stages of the disease. And then vein or artery occlusions. This example with its cherry red spot in the blanched out retina is an example of a central retinal artery occlusion. Typically, this is a very bad sign for a patient and has a poor visual prognosis. We have the assessment of the optic nerve. Again, a few things at our disposal as far as techniques to examine it. We have inspection with direct and indirect ophthalmoscopy, stereoscopic magnified microscopy with lens and a slit lamp, fundus photography, optical coherence tomography, and confocal scanning laser topography. Our normal findings are an optic disc with a physiologic cup and a cup to disc ratio less than 5. Here are our selected abnormal findings. All the way to the left, we see a patient with papilledema. This can be seen in patients with intracranial hypertension or MS. And here you can tell the borders of the optic nerve are very poorly defined. There are some hemorrhages. And this patient very likely has some impaired color vision, or might even have double vision as well. There's also nerve pallor. Here the disc and the optic nerve looks very white, very blanched. This patient might have had late stage papilledema that didn't get caught in time. And then an enlarged cup to disc ratio. This is typically seen in patients with glaucoma. And on the right-hand side here, we see a very normal cup to disc ratio, this little bright white area, pretty normal. It's not too enlarged. And here we can see where the cup is really starting to meet the edges of that optic disc. This patient very likely has advanced stage glaucoma. Lastly, let's discuss some special assessments and diagnostic techniques. Keratometry. Keratometry measures the central corneal radius of curvature. This test is useful for measuring corneal astigmatism in fitting contact lenses and prior to refractive and cataract surgery. Corneal topography provides a detailed mapping of the entire corneal curvature. It's used for contact lens fitting, prior to refractive surgery, and when assessing keratoconus. Here it's helpful to remember that warmer colors generally mean that something is much, much steeper. So red is a fairly steep structure on this cornea. Pachymetry is the measurement of corneal thickness. This measurement is important in assessment prior to refractive surgery of corneal dystrophies and of contact lens fit. A small ultrasound is used to measure the thickness of the cornea in microns. Specular microscopy provides a quantification of corneal endothelial cell counts. Endothelial cell counts are an important indicator of a progressing corneal dystrophy and also provide useful data to support endothelial health prior to intraocular surgery. Fundus photography is particularly important in retina offices that follow chronic retinal diseases, but is used widely across ophthalmology. This photography provides photographic documentation of the retinal fundus for documentation of fundus abnormalities, disc configuration, and pre-employment retinal mapping for individuals working with laser applications. Gonioscopy is the application of a mirrored lens to the corneal surface to examine the anterior chamber angle structures. This is an important test for determining whether a patient has open angle or closed angle glaucoma. Ultrasonography is used in ophthalmology for the assessment of structures when media, for example, aqueous, lens, or vitreous humor, is opaque. There are two types of ultrasound scans that we use. An A scan to determine the axial length of the globe for determining intraocular lens power prior to cataract surgery, and a B scan, which is helpful to detect retinal detachments, tumors, and foreign bodies inside the eye. Lastly, there's electrophysical testing, which involves visually evoked potential tests, or VEPs, and electroretinography, or ERGs. A standard readout of a VEP is seen here in the upper left corner, and this is a measurement of the health of the optic nerve while a patient is looking at a screen with electrodes that are attached in specific places on their scalp. Electroretinography provides a measurement of retinal electrical activity to assess rods and cones or both. It is commonly indicated for patients with retinitis pigmentosa, severe vitamin A deficiency, night blindness, or congenital total color blindness. And here we see this little doggy with a contact lens on his eye. This is how it's also tested on human patients. Typically, they have to sit in a room for up to 30 minutes to be completely dark adapted, and then they are provided with visual stimuli. In the field of ophthalmology, nursing assessment is vital for providing a strong foundation on which to develop care plans for patients. Ophthalmology is a testing-intense field with many different modalities in which changes in the visual system are evaluated and detected. Both nurses and ophthalmic technicians must be able to administer testing and provide patient support as needed based upon the findings of the examination. Understanding normal findings as compared to abnormal findings will inspire the highest levels of competency. Here are the references. Thank you for listening.